ready? You got me running. Shake it, shake it, shake it.
I am Meredith Hirsh, and this is Working Healthcare. When you turn 65, everyone says that you have won the health insurance lottery. Traditional Medicare is the gold standard. Unless you get dazzled by the confetti, those cheery Medicare Advantage ads promising dental, vision, and a $0 premium if you call in the next 10 minutes. This year, 54% of beneficiaries chose the lump of coal wrapped like a shiny new car, bow included. Medicare Advantage is the private alternative that bundles hospital, doctor, and drug coverage with glossy add-ons. But the fine print is where the story starts. Tight networks, prior authorization hurdles, formularies that shift under your feet, and ratings that promise more than they prove. People who know the system see the trade-offs. It's a dream deal until you get sick. That $0 premium can morph into thousands of out-of-pocket costs when the care you need collides with a rule you didn't know existed, and a choice made in the fall can be a brutal decision to try to figure out how to unwind in the spring. Two relentless patient advocates join me. Wendell Potter is a former insurance executive turned whistleblower who walked away from the spin. And Jim Mathews is a former MedPAC executive director, now at Health Policy Alternatives. Together, we peel back the glossy marketing to reveal the concrete consequences that decode incentives that quietly punish the sickest of patients. Stay tuned for a brisk, unsparing conversation about whether Medicare Advantage props up profits while weakening traditional Medicare. I ask questions that I am sure you are pondering. What are the actual rules? Does Medicare Advantage have to provide the same care as traditional Medicare, or just say it does? Who, if anyone, is reining in plans that quietly exit unprofitable markets? And if you picked a lemon in the fall, how do you get out of it in the spring without getting stuck? You'll hear blunt answers. Wendell and Jim don't hold back. They call out the worst Medicare disadvantage tactics and weigh whether physicians, patients, and policymakers can rally around concrete actions this year to put patients first. On Saturday afternoon, September 13th, I moderated the Future of Medicare Advantage panel with Wendell and Jim at the Coalition of State Rheumatology Organizations annual advocacy conference in Dallas.
So I have a lot of questions I want to ask the two of you. I was asked to do the presentation or panel discussion on the future of Medicare Advantage. I have a very difficult time calling it that. I like to call it Medicare Disadvantage, but I don't want to sway people, so I'll call them NA plans. But I have garnered a lot of questions from some in the audience, some from LinkedIn, some from people who are just very interested in learning more about it, and who you are the best people to ask. So I know that Wendell, you did our fireside discussion during lunchtime, and just in a few words, what was that turning point that made you want to leave the Cigna healthcare insurance world and actually work toward patient advocacy?
I think ultimately it was because of my awareness of what prior authorization really means and what delays and denials it means to a patient's family. And my team and I at Cigna handled what we refer to as high-profile cases or horror stories on a regular basis. So I knew they were happening, but it took one in particular that made me realize what the extent of the use of prior authorization is and what it means to patients and families and to doctors. And I knew it was prevalent then and it's even more so now. So that was one of the reasons. The other is just generally accepting my role in enabling these companies to get so powerful, so big, and so involved in our lives. United, for example, is so big that you can't escape giving them money one way or another, whether or not you're enrolled in the United plan. Cradle to grave, you are going to be, in one way, influenced by that company. And that company and others in that sector make the ultimate determinations as to whether you're going to get the care that you need, even if you are spending thousands of dollars every month, you and your employer, for health insurance. And that was coming to understand that. And I think it was because I was privileged to have a pretty senior position in the company. I saw all the decisions that were really made. Lower levels of the company, you don't have that visibility. But then when you are close enough to those who are really answering to their true bosses, which are shareholders and Wall Street financial analysts, then it becomes crystal clear what the motivations are.
And Jim, could you just briefly explain what MedPAC does for people who may not be familiar, and then why after 30 years did you leave MedPAC?
Sure, and I will be as candid as I can in this forum. MedPAC is a nonpartisan, independent agency of the legislative branch that has the sole statutory mission to advise Congress on issues related to the Medicare program. Obviously, payment is in the agency's name, and so MedPAC spends a lot of time on financial issues, but during my tenure there, and the agency continues to do this, they look at beneficiary access to care, quality of care provided under the auspices of the Medicare program, as well as the provider experience. One of the things that MedPAC does on a year-after-year basis is survey physicians about their experience serving Medicare beneficiaries. It is a unique organization in that it is data-driven, it is free from political or partisan influence, it has the ability to speak truth to power, and during my time there, I was privileged to lead some of the most dedicated and competent analysts that I've ever worked with in the course of my 30 years. And it is a very real thing for many of the staff on MedPAC to be able to say, here is a provision of the Medicare statute, Title 18, that originated with an idea that I had. And the staff can say, I ran it through Jim, which is the first hurdle, ran it through the commission, the second hurdle, ran it through the committee staff, the third, and then eventually in some form or another it gets voted into the law of the land.
So why leave?
I hit my 30-year mark in 2024. And having seen during my 10 years as executive director the caliber of discourse on the Hill erode and trying to read the tea leaves in the future, I decided I was done.
Right. So I'm going to ask you this first, and from anybody who was asleep the first part of this entire conference, what are the most egregious or challenging hurdles that patients face specifically in Medicare Advantage or MA plans?
First and foremost would be the first order decision whether or not to enroll. So they have a choice. The default is a fee-for-service Medicare, or they can enroll in a Medicare Advantage plan. Plan finder, again, MedPAC is to survey beneficiaries and do focus groups, can be tremendously difficult even for a relatively educated beneficiary trying to choose from 40, 50, 60 different plans in their local service area, and these plans are designed to stratify the risk of that local population in ways that are beneficial to the plan sponsors. Once they do make that first order decision, they need to determine whether or not their physicians are in the plan's network. They are looking at the plan's provider directory, which in many cases is a Swiss cheese. It was a Potemkin village with respect to the accuracy and validity of the names that are listed in that directory. The third thing is once they are in the plan and found a provider, prior authorization. This has been mentioned as a tool that either works in favor of judicious use of services or a tool that works in favor of returns to the plans of the shareholders. That is a major obstacle that the beneficiary and their provider faces. And then the last thing that I'll mention is obviously all of us will reach the end of this vale of tears at some point in our lives. And in many instances, a beneficiary who is suddenly incurred a dread disease, a fatal condition, they cannot find a provider who treats that condition in that plan's network. And either through their own fruition or through subtle or not so subtle mechanisms on the part of the plan, they find themselves out in fee-for-service. And when they are in fee-for-service, in most instances, they cannot get guaranteed issue Medicare. So they now face unended open financial liability for what is likely to be a very expensive terminal condition.
So those are 4 very good points. Do you have a couple to add, Wendell?
I think those cover it. I will comment on one thing at the beginning, one that is faced with a decision. Do you go with traditional Medicare and try to find and afford a Medigap policy or enroll in Medicare Advantage? These companies are allowed to advertise in ways that drug companies cannot get away with. In fact, the Trump administration is saying it's going to crack down further on drug advertising. Where is the scrutiny on the truthfulness of Medicare Advantage plans? They can tell you little goods, and little people can, and they do every single day. And we're going to be bombarded with those commercials. They're already beginning, but the panel will start very shortly. You will hear about free dental care or help with your groceries. What do they tell you about prior authorization, about network adequacy, and about the out-of-pocket expenses you will incur if you can't find a doctor or healthcare provider and you do have to go out? That is never disclosed. That is a huge, huge failing of our government not to require these companies to be truthful. And that's one of the things I'm going to be writing about and talking about, and trying to encourage the Trump administration and Congress. Where are you on this? Why are you letting this happen?
Yeah, no, definitely want to talk about that, and I have so many good questions about that. But in July, the House Ways and Means and Oversight hearing on Medicare Advantage focused on fraud, waste, and abuse, but large payers like United Healthcare and QBN actually didn't even testify. So Wendell, should for-profit insurers be in the business of offering MA plans?
I think they should not, as we have allowed them to actually control it. We spoke a little bit about the Medicare Modernization Act of 2003. The landscape was very, very different back then. There were a lot of plans that participated in the Medicare, private Medicare program, but they were all acquired or didn't make it financially. And you have seen that the big companies, the big for-profit companies, acquired what they wanted, or pushed other ones out of business, so just weren't able to compete with them. So we have a situation now that I don't think Congress intended at all. And I do think it is a very big problem that for-profits are not only in the program, but actually controlling it. Because, as I have said, and I'll make it abundantly clear, they're looking at this to make money, and everyone else is somehow supposed to enable them to do that.
What about you, Jim?
I'm going to jump in, with all due respect, with a little bit of a different perspective on this. This notion of ownership status was something that always came up in the deliberations on the MedPAC commissions. You had some commissioners who would often say things in public session along the lines of, well, we should have a higher update for nonprofits because they're good people. I never bought into that, and anytime it came up, I would tamp that down. And my position was always the Medicare program should be agnostic to ownership. Instead, it should set clear expectations with respect to, quality outcomes, whatever the requirements that the program puts in place to ensure that the programs are in the best interest of the people that it serves, the beneficiaries and taxpayers, and any entity that can meet those requirements have that. If you're a for-profit entity who can meet all of those standards and return dollars to your shareholders, great. If you're a nonprofit who can do the same thing, great. The Medicare program should be agnostic to that. Where I see a failing is largely on the part of the federal government, which has not imposed sufficient constraints on Medicare Advantage. Those guardrails do not exist.
So that's what I want to ask you. So MedPAC estimates that Medicare will pay about $538 billion to Medicare Advantage plans this year in 2025, roughly 20% more than those enrolled in traditional Medicare. So that is an $84 billion gap. So my first question is, how does that even make sense?
Yeah.
Well, it doesn't make sense. So I won't try to defend it, but it stems from an artifact of the way Medicare Advantage plans are paid. They submit a bid based on what they expect it will cost them to provide a standard A and B benefit to enrollees in their area relative to a benchmark, and that benchmark is set based on fee-for-service spending. Medicare Advantage plans are benefiting from two things. One, they have the ability to code their beneficiaries, their enrollees, to make them look sicker than they are. And so the beneficiary of diabetes in NA plan is not the same as the beneficiary of diabetes in traditional fee-for-service, but Medicare can pay them the same. And then Medicare Advantage plans are also benefiting from this phenomenon known as favorable selection. So in addition to actively coding beneficiaries as looking more sick than they are also able to identify in very sophisticated ways within a given risk group those beneficiaries at the bottom end of that risk group who are likely to cost less and say, hey, come on, this is the plan for you. And those more expensive beneficiaries are left to fee-for-service, and they are the ones who on the basis to calculate those benchmarks against which plans are bidded. So this is a true death spiral, to use a word or a term that is overused out in the environment.
So I would like you, Wendell, to answer the second part of that question, because you do so much writing on this topic. What is Congress and CMS doing, if anything, to rein in the overpayments and to protect the benefits and the access to patients?
Not enough, to be honest with you. There is interest, and bipartisan interest in addressing it to a certain extent. Senators Cassidy and Merkley, I think, are co-sponsors of the legislation. It's called the No Upvote Act. Senator Cassidy chairs the Senate Health Committee, some finance, as I recall, and he's said that he's really going to try to push, see if he can get it through this year one way or another, through either your spending bill or standalone. The odds of it getting through in any way are tough, and there are currently no House sponsors. I've talked to folks of Ways to Means, they haven't been too keen on the legislation. It could happen. It's encouraging that you have this bipartisan awareness and interest in this, but it's awfully hard to get anything enacted because of what we talked about earlier. The companies spend enormous amounts of money to try to keep things from being enacted they don't like. CMS, and I'd be interested in Jim's perspective on this as well too. They're not resourced well enough in certain ways. They don't have enough human resources, and they're under intense pressure from the carriers, the big companies. So it's They have, the big companies have inordinate sway with CMS.
So I'm going to help you into that, but I also want to put it with a little bit of a caveat. How much power does MedPAC actually have over Congress to rein in some of the misdoings of these Medicare disadvantaged plans?
None. No power whatsoever. MedPAC is purely an advisory agency. I stand by what I said a few minutes ago, that it is unique in its ability to speak truth to power, the ability to put forward unbiased, in my humble opinion, analytic work to guide policy development, and during the course of the briefings that MedPAC has with the congressional committee staff on a daily basis, MedPAC does the best it can to persuade both sides of the aisle with houses of the merits of his arguments, but at the end of the day, MedPAC has no power to make the Congress do anything. Congress is its own entity, and healthcare is one of hundreds of other things that is on the plate of a given member of Congress, a given senator, on any given working day.
So CMS assigns Medicare Advantage star ratings, and I'd like to know how those ratings are actually built and weighted, and is there evidence that plans gain them by cherry-picking measures or members? We've already talked about getting rid of different members or moving into different areas and ending coverage in a certain county potentially. And if they can do that, what changes would make the ratings actually reflect the outcomes?
As far as that.
Sure, you're the MedPAC man.
Yes. The STAR ratings program, or the QVP quality bonus program, is one of the major problems with MA that MedPAC has identified and continue to deliberate on over the decade or so that I was there. The first big problem that I would point out is, unlike value-based purchasing programs in the fee-for-service world, which are typically funded by a withhold from your provided payments. If you're a skilled nursing facility or hospital and you're participating in a VBP, there's a 2% haircut right off the top. And you can maybe get some of that money back if your performance is good. You lose that money if your performance is not good. It doesn't work that way in MA. In MA, it's money on top of the AD benefit. And last time I looked at this, it was in the ballpark of $12 to $15 billion a year. So that's problem number one. The second problem is, from my perspective, a lot of the measures that inform the star ratings are either very granular measures that don't really tell you much about the health of the population that is being enrolled in Medicare Advantage. So things that you care about, avoidable mortality, avoidable hospital readmissions, avoidable skilled nursing facility use, things like that. And instead they're very granular measures, and many of them are based on very, very small n sizes. So some of the measures are literally based on 411 chart reviews for all of United Healthcare. There's no statistical validity to measures that are derived that way. And where you see this is when we look at the macro level results. Something like 85 or 86% of Medicare beneficiaries are in 4-star plans or higher. And it's not in Woodland. It's not all plans are above average. It's not what's happening.
So I actually want to ask you, Wendell, Medicare Advantage plans continue to profit, and Medicare's trust fund faces insolvency risk. My thought that I will ever get traditional Medicare is like me winning the lottery or me seeing the UFO. That's apparently what Gen X thinks. Does MA's current design worsen Medicare's finances? Is this the cause for Medicare becoming insolvent?
I think it certainly is a contributing factor. I think there's no doubt about it. So much money is going to the plans that they're not really entitled to, that they would figure out one way or another to grab from the Medicare program, CMS, where they were talking about their ability to rig the upcoding, the risk scoring system, star ratings. They have been so successful in persuading Washington that these are things that will benefit patients, but in the long run, it is a money grab of these companies. And when you talk about $84 billion in upcoding just alone in this year, 1 year,
Yeah.
when you know it's going up, we're looking.
And that's all we've had.
Yeah. Yeah. In fact, there had been other estimates about other entities that have put it even higher. You're talking about $1 trillion over 10 years, and that was a number that started around quite a bit during the debate when it came to wanting to give the bill back. And the focus was on the Medicaid program. I'm not saying there's not, it's not deserted to look at fraud, waste, and abuse in the Medicaid program, but where is the attention on money that is right there and everybody, not everybody, but a lot of folks can see it's been documented. Why are you not going after that? I don't get it.
So here's another shocker for access to care. I live in South Florida, and Broward County has 355,000 Medicare beneficiaries living in Broward County. And the two largest hospitals just went out of network with Florida Blue. They went out, Broward Health went out July 1, the Memorial Healthcare System went out September 1. And this is just something that happened in my area. Then go up to Johns Hopkins, and August 25th, they went out of network with United Healthcare. And so after the Hopkins split, Maryland's insurance regulator opened up an investigation into UHC and their network adequacy and continuity of care practices. So my question really to both of you is, what are the continuity of care and network adequacy requirements for Medicare Advantage plans?
Well, clearly not adequate, and I think Jen probably provided more detail. Clearly not. And one of the things that's prevalent in these plans, and commercial plans too, are referred to as ghost networks. They're Swiss cheese. They're able to claim that there are providers that are in the network that are not, or you'll find providers that are no longer accepting patients, as you know. So it's a real problem, and there's just not enough attention focused on that. And and again, it's also, as Jim said earlier, very problematic as you get older and sicker. My mom was in a Medicare Advantage plan. I encouraged her and Dad to enroll in what was initially a John Deere plan in Tennessee. It was bought by United, and when Mom broke her hip, we realized there were no skilled nursing facilities anywhere nearby. That was of quality. She had to go to one, and they honestly told me that because she had developed head sores, to be honest with you, I should start getting her affairs in order. She was not going to make it. I disenrolled Mom from the Medicare Advantage plan, as so many people do, to go back into traditional Medicare. It's a problem, as Jim said, because you're not going to be able to likely get an affordable Medicare policy. But if it's a matter of life and death, you've got some resources, you're probably going to try to do it. And we did that with Mom. She lived another 10 years. But it's a big problem, particularly as you get older, to find adequate facilities and physicians in network.
But are there continuity of care requirements? Are there network adequacy requirements?
So there are network adequacy requirements, and continuity of care sounds so question. Not a clinician, and don't pretend to be.
Well, at least in my area, it's 98. But what are you going to do for 98, right? You're not going to move out of the area. You're not going to be able to get another plan until open enrollment starts. So I guess the big question is, what are the network adequacy requirements? And is the hospital to blame, or is the insurance company to blame?
I would argue, and by all means sort of differ if you need to, the insurance company. So each year in about February, CMS promulgates the MA Part D regulation. And within that rule, there's a very, very detailed table that lists provider types, hospitals, ambulatory surgical centers, skilled nursing facilities, home health agencies, primary care physicians, specialist physicians, 150 different rows in the table, and it's stratified by large urban areas, small urban areas, micropolitan areas, rural areas, and there's a number that fills in every one of these cells in this table, and that is the number of those kinds of facilities or practitioners that the plan is supposed to be able to guarantee to its enrollees who live in an urban area or a rural area. And so on paper, those requirements do exist. Where things fall apart is, as Wendell said, CMS is woefully under-resourced. And do you think anyone at CMS goes back and looks through the plan documentation to make sure that they do have the requisite number of nephrologists, the requisite number of home health agencies, the requisite number of critical access hospitals? Yeah.
So this is where I come in in Palm Beach County, and I actually had the opportunity with Emily Graham and Dr. Matty Feldman to testify to MedPAC and to speak to CMS and to talk about the network in advocacy of rheumatology in Palm Beach County, because in 2024, 23 rheumatologists were eliminated from Florida Blues Medicare Advantage plan. And all of a sudden, our patients had nowhere to go. And nothing was done. I actually did all of the research for MedPAC and gave it to them, and nothing happened. So, I guess I appreciate that. You are already retired. That's a problem. But what specific steps can practices take now to prevent these surprise terminations and then safeguard access for these patients? And then what can practices do for who were in my situation? Because not only is this a patient access issue, this is also an issue for our solvency.
Wow, you don't have much power, to be honest with you. Except raise a stink, try to make it public, and try to draw attention to it.
I got banned from TikTok.
Did you?
Yeah, that's completely.
Yeah, but it's really hard because they've amassed so much power and influence, and it's going to get worse. Network adequacy is going to be worse because these companies, Wall Street is not made pleased with the profit margins of these companies in the Medicare Advantage business, and that is why many of them have left certain markets, and why, like United's last earnings call, they count things to shareholders and analysts. They don't say in Capitol Hill or to the media, although the media listens in, but they are going to be leading some markets. They're going to be narrowing their networks. They're going to be eliminating many of the PPO plans, which means that the main options will be HMO. And I would argue that few people understand the distinction between PPO and HMO and realize how significantly more restrictive an HMO plan is when it comes to the network. And that the Johns Hopkins situation you mentioned, at least Hopkins' point of view, is that it's not over money, it's over the burden of prior authorization and the hassle of that. But it's also somewhat of a trend. I keep up with this. A lot of hospitals around the country are voluntarily dropping out of Medicare Advantage networks. Others are going to be dropped in voluntarily.
And that was in our situation. They voluntarily dropped out because they hadn't been able to renegotiate a contract in over 6 years, and they just couldn't afford it. That was even pre-COVID. We talk about how everything has gone exponentially post-COVID. Let's talk about UHC. Yes.
So I agree with Wendell completely that the problem of Medicare Advantage is going to grow over time. Currently, 54% of eligible beneficiaries are enrolled in MA. CDO estimates that will grow to 2/3 of beneficiaries by 2030. So that's the world you're going to be dealing with. I also agree that this is an asymmetric power relationship. And with all due respect to everyone in this room, the ability of any individual physician, the ability of any individual provider to fight this growing tide is nil. It's virtually zero. And so I will go back to what I said about the need for greater oversight. Going to the title of this presentation, Future of Medicare Advantage, I would say the future of Medicare is Medicare Advantage. But the only way it works is if that program is substantially and radically overhauled in a way that gives greater oversight to the plans through CMS. Providers and practitioners have a voice with CMS to bring these issues to the agency's attention and to affect changes. That's the only way this happens.
So I'm going to take that one step further, and it's a great segue. So United Healthcare, going back on what Wendell said, is actually set to drop about 600,000 members next year. And Humana expects to lose a few 100,000 MA members, and CVS Aetna warns it's going to lose about 10% of its MA membership. So what safeguards specifically can CMS institute to protect patients and continuity of care and even access to care? Congress knows that this is a problem. What needs to be implemented? I'll take one.
Yeah, I don't know, because they can and they do pick and choose where they want to market their product. They can file notices with CMS where they're going to be selling their products. But CMS doesn't have a lot of.
Yeah, and CMS is just so hypersensitive, so hyper-skittish about that non-interference clause.
Yeah.
They will not do anything that is even the faintest implication that they are getting in the shorts of the NA.
So let's talk about that interference, because I know we're wrapping up. So United Health's Optum, they keep buying the physician and home health assets, and CVS is the PBM that are dead. We've talked all about vertical integration. So why is this even allowed with antitrust laws? We talked about START laws and implementing that in core. There should be laws already in place that disallows this vertical integration.
There should be, and it's true. In healthcare and health insurance, they're created very, very different from other industries, and it goes back a long way, many years. Antitrust laws just did not apply. And now we're seeing the consequences of what is happening here. Some of the self-dealing we're seeing, and it's been mentioned at this conference, so like United, with its continued presence of growth in healthcare delivery, there's a line item on its financial reports called intercompany eliminations, and it grows over time. What that means is that they are steering more and more of their patients into entities that they own, the provider network, and consequently revenues are flowing from there to entities that they own. They can't aggregate all this and come up with a total because it inflates their, get kind of technical here, but they're doing that because they're able to pay themselves increasingly. And that is self-dealing that is a kind of practice that is not legal in banking, real estate, and other industries.
What resources does this group here have, and does our healthcare community have? Because Medicare Advantage is supposed to follow traditional Medicare Part A and Part B guidelines, and we all know that they don't. And we often feel handcuffs because again, the golden rule is the more the gold meets the rules. But what resources do we have? Where can you direct these folks to go to when they're trying to take care of patients or money is clawed back and they need to fight that?
I heard it last night, I think it did too. It is, and it's the whole reason for y'all's existence is to make your voice heard and to aggregate your voices and to be very vocal and very visible and very present. And I've been said, as a congressman said, it's important to get in touch with and be familiar with a congressional office, and particularly staff. I can't overemphasize that. You're exactly right. Staff are really, really, really important, and they certainly have an ear to loss, but they also are involved in helping to craft legislation and constituent services. My wife worked for a Republican congressman, so I know how important that is. But be visible and work and try to find some strange bedfellows, as one person mentioned earlier. What I am finding is that I'm seeing more on the provider side beginning to push back against our this industry. Is it too little, too late? I hope not. But that's the best hope that I think that we have, is to speak with in kind of coalition and with others in this work.
I want to end on one positive note, in one sentence or less, for you, Jim.
With that, looking me for the positive.
Yes. So, what one action can physicians, patients, and policymakers unite on to find some type of positive outcome with MA plans?
Time's up.
Thank you, guys.
I hope you enjoyed that panel discussion about the future of Medicare Advantage as much as I did. I'd love to hear your comments. To everyone listening, the full video of this episode is now on YouTube. Search Working Healthcare and hit subscribe so you don't miss future interviews, short clips, and behind-the-scenes moments. Got a question, an episode idea, or someone you think I should feature? Drop me a line at meredithhirsh.com. If this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. You can follow Working Healthcare on Instagram, Facebook, and YouTube, and connect with me on LinkedIn. That's where we keep the conversation going between episodes. The more voices we bring into this space, the more momentum we build, because change doesn't start with a policy. It starts with a real conversation, like this. New episodes drop every Tuesday. Subscribe and don't miss what's next, because you can't fix American healthcare until you understand how it works. Tune in weekly with me as we explore the inner workings of healthcare.
You ready? Yeah, you got me running, got me running.